I've seen it from a lot of different perspectives.
Yeah.
And I think working in global health is a lot about understanding the context that you work in and the ways of working in different countries, different cultures. And that's shaped, I suppose, the way I see the way we can work in the HSE.
Hello and welcome to another episode of the HSE Talking Health and Wellbeing podcast. My name is Fergal Fox and today we're talking about global health. Our guest today is Dr. David Weekliam. He's a consultant in public health medicine and director of the HSE Global Health Programme. David, you're very welcome to the podcast.
Thanks, Fergal. Delighted to be here.
So, David, when we're talking about global health, I know you're going to describe in a lot of detail the work of the Global Health Programme in the HSE, but you wanted to talk about what global health is as a concept. Can you introduce our listeners to what we're talking about here?
Yeah, it's a good starting point, and I'm reminded of the title of the European Union Global Health Strategy, which is Health Has No Borders.
Okay.
I think that captures it very well. And when I came into the HSE in 2007 and talked about global health, a lot of people thought I was talking about other countries, other parts of the world, about charity, about aid.
That would usually spring to mind to me now, yeah, that it's about maybe helping other underprivileged countries or countries with health systems not as developed as ours.
Yeah, but it was more than that. And I think what the concept of global health is making us think of health in a different way. It's about how, when it comes to health issues and things that affect our health, we're interconnected. Countries are interconnected. And so it makes sense then for us when we're addressing our health issues in Ireland to be working with other countries, to be learning from other countries. We benefit from working with them. They can benefit from working with us. So it's not about a particular place like health in Africa, health in Sudan, but global health is about health everywhere. And we need to have that understanding if we're to provide good quality healthcare in Ireland.
There's interdependencies on other countries in terms of our, like I think immediately of our workforce, but in terms of what we're vulnerable to.
Exactly.
That's the big thing, isn't it?
Yeah. And we're not long after the COVID pandemic. And I think that showed us very starkly how we're connected with other countries. COVID didn't start in Ireland. And it became clear very quickly that if we were going to control the epidemic in Ireland, we needed to work across borders with other countries. So that's true of other disease threats that we face. And there's many other ways in which we're interconnected. We've a large migrant population. Now, about 20% of our population were born outside Ireland.
Right.
So we need to, as we look at our own health service, understand health in a much more global way, where people are coming from, views about health, how they understand health and healthcare, and their health needs that are different sometimes to people who've grown up in Ireland.
Yeah, that's very true. I was just talking with my colleague in national immunisation in the HSE about vaccines and immunisation for people coming in from other countries, and that cultural mix of communications and engagement that we need to have, put effort into understanding where all these people are coming from geographically, but then culturally.
Yeah, exactly. And I think that's what we need to see for our own health service, that it's very important to have this global perspective. And the other side of that is that understanding that we also have our own relation to health in other countries as we're interconnected. And when I think of global health, one thing that strikes me so much is the stark difference in health in Ireland compared to some other countries. And I'm very privileged to live in Ireland where we've got good health, but health is not the same everywhere. And people live generally in lower income countries. People have poorer health and poorer experience of healthcare. We've a responsibility, not to consider that and to see how we can help address that. It is about inequity, it's unfairness. And I think that's what I think gives us that responsibility.
Yeah, so we've a social responsibility to look out and to be aware of other countries and offer our learning and resources in some way.
Exactly, yeah.
Is that one of the ambitions behind the HSE Global Health Programme, to kind of have outreach and to look at linking in with other countries that would require that support?
Yeah, and I think that's what, I suppose, inspired the setting up of the Global Health Programme in the first place. And while I've said global health is something about what we all do, it's how we look at health as something in a global way to improve healthcare, whatever our role. Nonetheless, we have a particular opportunity and I think challenge to see how we can improve health for other countries. And so with the setting up of the Global Health Programme, we saw that was having a twofold goal. One is to contribute to better health in the world. And that is particularly looking at some of the poorer countries with low resources. And also how we improve health in Ireland to taking more of a global approach and, like you say, learning from other countries and working together with other countries. That's the way the programme has been set up, and it's become an important part of what we do in the health service. It's in our national service plan.
You started off the HSE Global Health Programme in what year?
That was in 2010.
2010. Okay. You've grown the programme And what would you see as the key actions that you're taking?
Yeah, I think the biggest part of our work is what we do with other countries to improve health. And we would see that in the context of how Ireland contributes globally.
Okay.
So we have a close relationship with the Department of Foreign Affairs, and we contribute to Ireland's international development policy, which is called A Better World. And we're also represented on the government's interdepartmental committee, which is looking at how Ireland engages broadly in development. And Ireland works, as other countries, within the framework of the United Nations Sustainable Development Goals. And one of those goals is about better health and well-being for all. So that gives us a framework for how we work with other countries. And then we have to be mindful of our role. We're not an aid program. We don't bring money. That's not our role.
Yeah.
But we have within our health service a wealth of experience and expertise among our staff across the organisation. And that's something we can share and that we can contribute to working with other countries. So that's the basis of how we work.
Well, my perception of Ireland's position in that aid programme is that we've been traditionally seen, or we felt it anyway, that we're a generous country. There's a package of aid that the Department of Foreign Affairs are coordinating. The HSE are a partner in that and a voice around the table. And then, as you said, there we're sharing our intelligence and learning. That's our key asset.
It is, and that doesn't cost much to share that. So it makes it to be a very, both an effective and a very efficient in terms of value for money way of providing development assistance. And I see this sort of as a hand-in-glove relationship with Department of Foreign Affairs. While they're giving aid, we're providing expertise that complements that. And with that kind of approach, we're then, in our focus of countries that we work with, are working in countries where Ireland is already engaged through bilateral aid programs in Africa. And then we work together in those countries.
It's a multiplying factor on the maybe physical resources or human resources that are over there, having this health intelligence, sharing that health intelligence. You can't even cost it. I know it's a free resource for us to share learning, but you couldn't buy that intelligence.
Yeah, it's a very practical way of providing assistance. And I can give you sort of examples of how that works. But the basis of working with countries, and we work in 5 countries in Africa. So they're Ethiopia, Mozambique, Tanzania, Zambia, and Sudan. And we don't just go into these countries on our own initiative. We go in when we're invited. The basis is partnership. And partnership means we work with a shared purpose to work together to something common goal, which is to improve health in both our countries because we have shared challenges. But particularly the focus on the lower income country. And we're invited in and we listen to the government, the ministries of health, other stakeholders there to understand what the challenges are that they're facing and what they think it is that we can bring by way of working together to address those. And partnership is about a long-term relationship. I think we all know from our own health service, it takes a long time to bring about sustainable change, sustainable improvement. So we don't go in just to work short-term, but to work together over a long period of time to try and strengthen the health service. And then that's based around the priorities that the country themselves develop.
I get the administrative and the business side and the partnership working isn't overnight. But give us an example from one of those countries that you just mentioned.
Yeah. So if you think from these countries, and these 5 countries combined, it's a population of over 300 million. They have very big health needs. So if you think of these countries, there are more than 10,000 women across these countries die from complications of childbirth every year. Something like 300,000 children under 5 die every year.
Well, they're shocking statistics.
Despite so much improvement and progress that has been made, there's still some very, very big health challenges. And these are countries with very scarce resources. So the kind of resource levels they have are maybe 1 or 2% per capita of what we have in Ireland. So to give an example, and from Mozambique is a country we've worked the longest time, and we were invited there to work with them to strengthen the health service. And what they identified as a particular challenge that they faced was the poor quality and safety of care in hospitals. So these are low-resourced facilities, and they were experiencing some not good outcomes for patients. A lot of deaths in hospitals from very ill patients, from women, and other problems with providing good quality healthcare, long waiting times, and so on. So we worked together over years to provide training for teams from hospitals, the main hospitals in the country, 14 hospitals we've worked with. And we provide training so that they learn how to address the problems of poor quality in their hospital. And they identify what the problems are, often very similar to the kind of problems we might have in Ireland. And then they learn how to address them. But we don't have more resources. The resources are scarce. But yet, even with the resources they've got, they can still make big improvements. Just one example, and I give you now from many of the hospitals, but one hospital called Jose Macamo Hospital, a 400-bed hospital, their big problem was that they had a very high death rate within 24 hours of patients on their medical ward. So this is a very challenging situation, an 80-bed ward, only 2 nurses on duty most of the time. Sometimes patients coming in very sick, challenging to monitor and to keep those patients well. Through the training that we did with them, we introduced them to some methods for better monitoring of patients. We used a tool that's used in Australia called Between the Flags. And we translated that into Portuguese and made this available as a tool they could use to help them better monitor the patients. And at the beginning, they were reporting that 11 patients per month on average were dying within 24 hours. At the end of the training period, it was down to 4. So we saw real results in terms of lives being saved by them providing better quality of healthcare with the resources they have. What was very satisfying then to see was the training was in 2017, that they continued themselves with very little involvement from our side to continue to improve. And they reported that they reduced their deaths within 24 hours on the medical ward from 58 down to 8 over a period of a couple of years. Then we had COVID and we were less involved with COVID. And when we came back and visited in 2023, so some years later, we saw that that improvement had been sustained. And that showed us, and as we saw with similar sustained improvements in other hospitals, that this way of working can be very effective, using very limited resources by providing training and other ways to improve people's capacity to provide better care.
You were bringing a culture of service improvement. You seem to have impacted on that, making them realise big improvement was achievable.
That's true, but also by finding the right people to work with who were very committed to providing better care and just needed some enabling.
Yeah.
And that was true of people in the Ministry of Health who led the program, but people from the hospitals. And the Ministry of Health did a very good job selecting the right people from the hospitals who were very committed to improving care.
Yeah.
And were able to avail of the kind of trainings and support that we could provide.
The statistics that you're highlighting here, David, are very stark. Like for us living here in Ireland, I know you set out earlier in the podcast saying that it's a human rights, it's a social justice, but when you throw those statistics about deaths in that size of a hospital, it must be awful stark and sometimes bleak to hear the reality of some people's health systems.
Yeah, and on one hand, it's very positive to see how much progress countries have made and to see the statistics I spoke about about child mortality and maternal mortality. They have improved so much in the countries we've worked in, but there's still a long way to go. And the challenge is to reach everyone, people who are not reached. And the Sustainable Development Goals has a motto, leave no one behind. And I think that's the challenge countries face. And they have this goal of universal health coverage, a goal we would also share in Ireland, is how does everybody get the health care they need without experiencing financial hardship?
Yeah.
And so we're working with these countries to try and help them achieve that, to really reach those people who are not being reached with healthcare at the moment and who end up having poor experience of health and poor healthcare outcomes.
It must be a great motivating factor to think that experiencing a project like that and they're able to support, as you said, the key drivers or the key champions that are locally employed to support the service improvement and completely change the way things are happening.
Yeah, and for that to work, a lot of it about the way we work. And I started off talking about that because it's so important. It's very important we don't go in with our own agenda, our own ideas of what's needed, but to find out how they understand their health problems and what are the issues they're wanting to work on. So if we take another country, Tanzania, which is a more recent partnership, we've been working there since 2022. And again, the issue of quality of care came up, but in a different context. And in Tanzania, the government has done a remarkable job of expanding healthcare so that nearly everyone now has access to healthcare. But as they did that, they recognized, well, that's all very well, but if people don't get good quality care, they won't get good outcomes. So that's very central in their thinking. And they asked us to work with them on improving quality. But in Tanzania, it wasn't hospitals they asked us to work with, but community-based facilities, primary care facilities. And this is where most people get their care. So this is really important. But a different challenge. There are more than 10,000 of these facilities in Tanzania. So we can't achieve much by going in and doing a few trainings.
Yes.
So this is a different approach whereby we've worked together with them to devise a training program that they can then deliver, that they can scale up and spread across the country. So that involves a carefully planned and considered program of how to train people in the facilities, addressing the problems that they experience in the facility, how to use training methods that are going to enable them to reach everyone, which is both in person, is also going to need virtual training, and then how to support them in their training, that if you train people and leave them in remote, difficult circumstances, it's going to be very hard to bring about improvements. So training needs to be accompanied by good supervision and support, by coaching, mentoring. So our program has been to work very closely with people in the government and the Ministry of Health to develop this and to help develop their capacity to be able to roll this out. And some of it does involve training, but it's not just training people in better care, frontline workers, it's training trainers, but training trainers who will train trainers.
I understand. Yeah, you're taking a strategic cascade.
And it's a long-term measure. This is going to take years for full impact. But if that can be realised, that they can improve the quality of care a little bit in every facility, this will have a very, very big outcome. And again, like Mozambique, a lot that's achieved with a relatively small amount of resource.
So where is that at now? One of your kind of key things that you're highlighting to me here is the process and the partnership. It's not overnight. It's not coming in with the patriarchal, we know best. It's the opposite, really. You're going in listening, you're going engaging, you're trying to address issues that they're highlighting so you can build a kind of supportive collaboration. So in terms of that last example of that cascade train and model and the mixed methods and all that, where are you at now with that? How long did that take to develop?
Well, that work started in 2023.
Okay.
And it's been very intensive for the last year. And it's at a stage now where the program is being piloted in rural and urban areas. That will be piloted over the coming months, be completed within a few months. And then it will be for the Ministry of Health to adopt the program and to implement. Our role is not to implement. Our role is to support the development. So they will then need to include that in their own service plans and budgets so that that can be then gradually rolled out, scaled up over a number of years then.
So it belongs to them. They have the ownership of it.
Exactly, yeah.
That's interesting. And then in terms of your partnership with them and the development of that program, are you consulting or how is that collaboration working on the content of the program and the needs of it? Give me some insight into that.
We use a word like co-production, co-development, and it's very much about together.
Okay.
So everything we do together. So we have various groups that we set up in with people from the different parts of the government who are involved and ourselves. We also work closely with a local non-governmental organisation called the Benjamin Kappa Foundation because they provide some local expertise for us and can be also involved in the development. And everything is decided together and agreed together.
Right.
And they're always in charge of the implementation and we support that. It is very intense engagement and every week there's ongoing keeping in touch and developing.
Yeah, but it must be very rewarding seeing that you've got an opportunity here and we need to make the most of it, that they're willing to take this on and you're just trying to support the process.
Yeah, and it's about, for our side, it's been very flexible too.
Right.
We always have to be able to adapt and tailor to where they're at, the timeframes that work with their timeframes, not our own timeframes. Sometimes priorities change. I mean, to give an example, Ethiopia, where we started the partnership there in 2019, and we were undertaking work with quality of care in hospitals. And then COVID came and we couldn't visit. So that was a big disruption to the partnership. But during COVID, we had the opportunity to avail of some funding to support health workers during COVID. And we discussed with the Ministry of Health how that might be helpful to them. And one of the big issues for them was that their health workers in their COVID treatment centres were under huge stress. And they wanted to see how they could provide support for their mental well-being.
Yeah.
And they developed a program of emotional resilience workshops. And we were able to support that during COVID. And from our side, we couldn't visit, but we brought a team together of people in Ireland with expertise in psychiatry, psychology, the relevant expertise to give advice on that and on what's good practice and to help them design the program. They implemented the program very successfully and we visited then after COVID and we could see the very successful results of those workshops that really made a big difference to the well-being of health workers and it was a model that then could be replicated in other situations. That was an example for us of how when the situation context changed, we needed to be ready to support what their needs are.
Yeah, I'm guessing that COVID was a game changer for every country. So the context changes, but I'm guessing in some of these countries, there's going to be different issues coming up on an annual basis. They're going to have to be changing direction or looking to address and meet.
Yeah, and as we are working closely with them and we're regularly in discussion with them, then different opportunities will arise. Yeah. So after, for instance, in Ethiopia, taking that example, having worked with them in the area of mental health for health workers, that led to engagements around the needs for mental health professionals in the country. And a big gap was identified in the area of clinical psychology. They are trained very, very few clinical psychologists. So there's a need. This is a country with 130 million population and they maybe train 5 clinical psychologists in a year.
Right.
And a real interest in the university, the Addis Ababa University, where the training takes place to redevelop and strengthen that program. So we developed a link there. We worked here in Ireland. We developed a link with the University of Galway, where they have expertise, and we assembled a team of people with expertise to work together with them. And that has enabled them to strengthen their curriculum, to improve their supervision, to develop their whole program.
Capacity build in a supportive way.
Yeah.
Can I move back one step? When you're having these initial discussions, I presume you have to have some sort of a partnership agreement or a memorandum of understanding or something to kind of say, this is where we're setting out from.
Yeah, this to us is very important, that we work towards having a very clear arrangement the way we work.
Yeah.
We work towards putting in place some kind of agreement, memorandum of understanding, which is a framework for engagement. It's not a work plan. From our side, I think it's very good in that it's stating our commitment as our health service to work with them and to identify the key areas of where we would work with them. And that's about improving services. It's about addressing issues of quality of care that I've mentioned. A lot of it is about strengthening their workforce, because that's something that we can help in terms of building capacity if they can strengthen the training of their workforce. And these member understandings, they're not signed by our program, by me as the director of the program. These are signed by the head of our health service.
Yeah.
These are HSE commitments. It's the commitment of the Irish Health Service to work with their health service. And that's important because that allows us then, as we engage them, is to draw on other resources within the health service, because we have a small team of 4 staff. We're limited on what we can do with others, but we can draw on expertise right across our health service and beyond as well. But it's a commitment of our health service to work. And these framework agreements then allow us to work long-term. It's about the long-term relationship.
Do you put a time span on it and say, look, this is 3-year, 5-year, or do you say, look, this isn't short-term?
I think the commitments at different levels. I think when we start, it's long-term. I'm thinking 10 years more. Because we can have that long-term commitment, because our staff, we're here working for our careers. We can work for years into the future. But then to work that out very practically, a memorandum of understanding will think in terms of 3 to 5 years. So what can we do over that period, the medium term?
Yeah.
And we see what some of our goals and objectives can be. And then year by year, then we discuss the plans for each year as to what needs to be done. And then we agree on those work plans with them.
You mentioned an example from Mozambique, Ethiopia and Tanzania, but there are 2 other countries, Zambia and Sudan. Am I right?
That's right, yeah. So each country is different, and this is very much, it's the way we work. It's not a set way of working in each. The story of Zambia, it goes back a bit like Mozambique. It's about 10 years, and it started with a request from a hospital in Zambia for an ultrasound machine. That prompted discussion in the HSE. Well, okay, they need an ultrasound machine, but what about all the other equipment that we replace on a regular basis? That's still in good working order. Maybe there's something more than an ultrasound machine. And that led to the development of an initiative called the Equals Initiative. And it's a partnership between the HSE and the Royal College of Physicians. And it started with that idea of sending equipment, and we've been sending equipment to Zambia now for about 10 years. But it's more than sending equipment. And from the very beginning, we're very conscious that if you send equipment, it needs to be used well and maintained. We know from statistics, evidence, that so much of equipment that gets sent out doesn't get used because it's not the right equipment, or it's not maintained well, or people don't know how to use it. So as part of our program of sending equipment, we clinical engineers in the HSE have been providing support to develop training for clinical engineers. And we even provided toolkits for hospitals so that they could maintain the equipment. But the program then went on beyond that to thinking of the services that people need with the equipment. And the partnership with the Royal College of Physicians brought that focus to around training, and particularly specialist training for doctors. When we started, Zambia didn't have its own specialist training program like we have in Ireland. We have many training bodies for different specialties. And through the relationship with Zambia, they started up their Zambian College of Medicine and Surgery. And we provided support along the way to help them develop their strategy and to build up the college. It's still at an early stage, but now, 8 years on, this year, their total graduates reached 388 specialists across 20 specialties.
Right.
So this is now nearly 400 specialists who've been trained in Zambia. And if you think about the way it was a decade ago,
which isn't
these
that long,
training programs weren't there. So doctors who graduate in a country like Zambia, who wanted to become a specialist in whatever area, would go abroad for training, and most times they didn't come back. This is a much better approach, because doctors, if they can have their specialist training in the country, they'll most likely stay. So this is building up capacity in the country. And what's good to see is that these doctors are not just based in the cities. This is now helping develop specialist medical care across the country and providing essential life-saving services. And that ties in with the sending equipment, because when we send equipment, that's providing equipment that can help with their training, but also then when they're providing the specialist care.
I remember you telling me this a good few years ago when you were telling me about initially an example of equipment going over. I had pictured in my head a container with somebody just taking out old HSE equipment and saying, good luck with this stuff. And you were telling me about that quality approach around, it's no good to you if you can't use it. But that ultrasound and that example you're after given with support for surgeons and training, and that's such a deep example of the depth that the equipment can be used, or the partnership that's been built on it with the Royal College.
Sending equipment, it's a complex process to do it well. And it's really been enhanced in recent years. It was for a number of years, it was just Zambia. Then during the COVID pandemic, we had surplus equipment that at a certain point we weren't going to be using ourselves. And then there were huge needs when there were COVID crisis in India and Nepal, and we sent hundreds of ventilators and oxygen concentrators, new equipment to those countries. And then we sent 41 containers of PPE to 5 countries in Africa. And that really took our donations program to another level. And we've been really building it since then. We work very closely with the National Equipment Replacement Program. The idea being that all equipment that's being replaced and the replacement is planned, that would be considered for suitability for donation.
That's a big scale then.
And we have a warehouse where we're able to hold the equipment then before we donate it. And our donations is not just Zambia now, that we donate to other countries. We've now been donating also to Ukraine and to Sudan. And they're countries in conflict situations.
Yeah, tell us a bit about Sudan, because you've given us a bit of insight into the other countries. It's disappointing to hear that obviously conflict is one of those context pieces that you just have to deal with.
Yeah, our relationship with Sudan is different to the other countries because it's founded a lot on the fact that we have in Ireland, we have many doctors working who from Sudan. I mean, there's more than 1,000 Sudanese doctors registered with the Medical Council.
In Ireland?
In Ireland.
Oh.
This is the second highest of any country after Pakistan. So that's a huge resource in Ireland of people with expertise who know the country well, who are a very important link back to support. But also I think, our health services benefit so much from having these doctors work for us. It's really good that we would look at ways then to also be supporting the health system in Sudan. So there's a long-standing connection between our countries. And over the years too, Ireland has been involved in supporting different crisis situations in Sudan. So we've had a collaboration with Sudan for a good number of years. And we had an agreement that we signed in 2017. And then we renewed that after COVID. And only just after, the month after we'd renewed the agreement with the Ministry of Health, conflict broke out and Sudan has been in just a state of civil war since then.
Right.
The health system has been totally disrupted. There's been damage to health facilities right across the country. It's not been possible for us to visit or to do a lot of the collaborative work that we had planned. So during this period, we've been wanting to try and maintain our solidarity with Sudan, to do what we can. And what we've been able to do has been to send equipment to support the health facilities just to keep them running.
Okay.
And we sent some equipment last year. We've just now had 2 containers now just left last week to go out, and they're going to go to support a hospital in Khartoum, and the Soba Hospital. And that's a hospital we're going to work closely with to help restore health services and help build up their capacity again.
You're going to have to work with them for a good few years then, if that's the state the health services in.
There's going to be huge needs there into the future, for sure.
Have you a system of pulling on the resource? You mentioned that there's so many Sudanese doctors in Ireland. How have they been able to support the work, or have they been able to do that? Yeah,
there's work in regular contact with different Sudanese doctors, and they have some of their own organised associations and groups who work together. Sudan is part of an initiative that's run by the training bodies and the HSE, National Doctors Training and Planning, called the International Medical Graduate Training Initiative. And under this initiative, doctors from Sudan have been coming to Ireland for 2 years for specialist training, and then they go back to Sudan. That's a condition of them coming over. And Sudanese doctors in Ireland have been involved in that work in supporting doctors coming over. And through that initiative, we've been involved as well with doctors.
Isn't there intense competition? Like we mentioned COVID earlier, and in those times, I know that you referenced making donations around equipment during COVID to some of the countries, but during COVID, we had intense international competition around access to vaccines, and on an ongoing basis that we have competition around healthcare staff. Like there's international competition for healthcare staff. That's the simple fact of it. So that global view of the world, but then the real problems is, getting the resources and everybody concerned about their own. it is a challenge, isn't it?
Yeah, and I think we've seen how much the world has changed when it comes to global development and global health. We've seen huge cuts in aid, and that's not just the US, it's across Europe as well. And that's having a big impact on some of the poorer countries. I was recently in Mozambique, and we learned that they had a $500 million cut in their aid from the US, $500 million.
Yeah.
That has a huge impact and will have a huge impact. This is money that is needed for life-saving treatments like HIV drugs. It's needed for central family planning. It's needed for vaccines.
Yeah.
So it's a very difficult situation globally for the lower income countries when it comes to essential healthcare, because they do not have sufficient resources themselves to meet all the health needs. And so for some years to come, there will be a need for this assistance. And there's a big challenge in the world in how that can be organized when countries are much more thinking of their own needs, more than thinking of the global needs. And I think this is why, coming back to the concept of global health, it's very important to remember that because health is global, our support for the countries is not just about helping them, it's actually also about helping ourselves. And you remember in COVID, we talked about we're all in this together, or no one's safe till we're all safe. There's an imperative there for us to work with these other countries to help them build strong, resilient health systems for their sake, but also it's something that will benefit ourselves.
Yeah.
And it's a two-way benefit. And that's, I think, the case. All of the work we do in global health, or our global health program, is understanding that it's a two-way benefit.
Yeah. One of the other things I wanted to ask you about, the partnerships that you support between some of the health departments or hospitals and other places in the world, as well as having the partnerships with the countries that you named. You facilitate and you support other partnerships. Can you describe a bit of that?
Yeah, that's right. I mean, that was from the beginning when the Global Health Programme started. And I remember with the CEO at the time, Professor Brendan Drum, he was very interested in the idea that we would have twinning arrangements between different parts of our health service and counterparts in other countries.
Yeah.
So it might be a hospital in Ireland twinning with a hospital in Sudan, or it could be a public health department, or it could be a primary care facility. And this is an important part of the way our health service works with other countries. So while we work in our global health program at that national level with the governments, I think right across our health service, you see lots of examples of our health services and our institutions like hospitals twinning with counterpart similar institutions in Africa and Asia and low and middle income countries.
Give us an example of that, or one or two examples if you can, because I think people would be interested in that.
Yeah. The one that inspired me a lot when I came into the HSC was a partnership between the Cork University Maternity Hospital and the Omdurman Maternity Hospital in Sudan, which at the time had 36,000 births a year, which is...
Well,
it's more than the 3 maternity hospitals in Dublin combined, huge maternity hospital. And with many challenges, because many women were coming into the hospital very late. They normally would give birth in the community at home. They would come in when there were difficulties, so high risk situations and high mortality rate. And the partnership with Cork involved developing links with the hospital. And there was a Sudanese doctor, Dr. Sami Ahmed, based in Cork. And through the collaboration, they provided training, they had exchange visits, they'd send equipment, they did research, so different types of support and things, interventions to improve services. The mortality rate of women in the hospital reduced by over 80% over a number of years of the partnership. Now, there were other factors as well. I'm not attributing all this to the partnership, but you could see how the partnership made a very, very significant difference to improving the practice so that there was much more standardized good practice for these women who were coming in.
And there was a Sudanese doctor leading the charge in Cork.
In Cork, and others in the maternity department.
Yeah, that's fantastic, yeah.
And that's the type of model that we've been advocating for. We don't think it's a good idea just to go in on your own, just to provide some assistance to another country, even if you're very skilled and have lots of skills to share. It's much more powerful when it's a team approach, a multidisciplinary approach, and when it's a whole institutional approach, because a hospital works like it's a system. You need to build up all parts of the hospital for the service to work and be sustainable. And like we have agreements in place ourselves with countries we work with, we encourage people working in the health service who are engaging in this type of work to develop agreements with these hospitals to set out how they're going to improve the services, and also to think of it as a long-term relationship and to understand the two-way benefit. And we learn from these relationships as much as they're learning from us.
Yeah. You definitely change your perspective on healthcare, on life, when you experience some of the things that you're telling me.
Yeah, the thing I often say is that there's so much we can learn from countries that have huge health needs, far more than we have.
Yeah.
And with a fraction of the resources we have. And they have become very adept at using resources well. and the understanding how to organise the resources to get the best results for their patients. And in Ireland, we're maybe not so attuned to that because we're a wealthy country where we're generally a healthy population.
Yeah.
And there's a lot we can learn of what really matters in the way we provide healthcare to get the results we're looking for, and how to better organise our health system. And you see in the countries in Africa that we work with, they have very good primary care-based systems. In Ireland, our system has been more hospital-based, and now under Sláinte Care, we're moving to strengthen
the primary care
system. And there's lessons we can learn from other countries and how to do that well.
So, David, I know you've been working in this area a long time. I met you initially when you came to the Midlands. You were working in public health and you were supporting our work in traveller health, but you were just back from out far and doing this type of work on the ground. Can you give us a bit of insight into that? How did you get into this way of working and way of thinking? Because ever since I know you, this has been, one of your key interest areas. That's something that you wanted to do.
Yeah, well, that goes back a long way. I mean, I went in to study medicine because I wanted to work with other countries and to improve health in other countries. And that, I suppose, came out of that sense of maybe that inequity I spoke about, that unfairness, where I'm privileged to be born in Ireland and have good health, and there's people in other parts of the world who don't have that experience and wanted to do something in that area. So that led me into studying medicine. Then I specialised in general practice and public health. And then I went initially to Sudan for a few years and spent some years in Africa. And then I spent 9 years in Nepal, working there with a non-governmental organisation to improve health services, working with hospitals and community health projects. Then came back to Ireland and worked with Irish Aid in the Department of Foreign Affairs for a few years as health advisor. So that was a learning experience for me, of working with governments and with ministries of health.
So you've seen all sides. You've seen lots of the angles on this.
I've seen it from a lot of different perspectives.
Yeah.
And I think working in global health is a lot about understanding the context that you work in and the ways of working in different countries, different cultures. And that's shaped, I suppose, the way I see the way we can work in the HSE. And so when we joined the health service in 2007, I was bringing that experience in to see how as a health service we could work with countries to improve their health services. And then what struck me coming into the health service is how much we also needed ourselves as a health service to be more globally connected for our own sake.
Yeah, you keep emphasizing that point that it's a win-win. Other countries under-resourced health services can utilize us, but we definitely need to change our way of thinking, and we've a lot to benefit from their experience or for supporting their systems.
Yeah, and that's something that, hope we can, develop more in the HSE. And from our perspective in the Global Health Programme, we've recently moved from one part of the health service into public health. And that opens up, I think, opportunities for us to connect more widely with other parts of our health service that are engaged in addressing similar issues in Ireland, and to see how we can bring that more global approach into our work.
Onwards and upwards. You're looking for opportunities all the time.
Always.
Good stuff. Okay, David, I want to thank you for coming in today. This has been a very interesting conversation, so enlightening. I knew a little bit about your work, but given those granular examples of the work in the other countries and some of the really very concerning statistics that other health systems are experiencing, kind of really highlights the need here. So I'd like to thank you for coming in today. David Weekleam, he's a consultant in public health medicine and director of the HSE Global Health Programme. Thank you very much. And I'd like to thank you, the listeners, for tuning in to another episode today. If you want to learn more about the Global Health Programme, you can check out the HSE website, Global Health. And if you want to find out more about HSE Health and Wellbeing, you can also look at the HSE website. We're also on X, LinkedIn, and have lots of great videos on our YouTube channel. So thank you for listening to another episode of the HSE Talking Health and Wellbeing podcast.